Welcome along to the Prevention is the New Cure podcast. I'm Steve Bryan MP, Chair of the Health and Social Care Select Committee in the House of Commons.
And I'm Helen Stokes-Lampard. I'm a General Practitioner, GP, Chair of the Academy of Medical Royal Colleges and Chair of the National Academy for Social Prescribing.
Can you fit that on a business card? So this is a brand new podcast. We discuss all things health and NHS related with a political twist. Of course, it's the number one issue with the British public at the moment, and always, in fact. So during each episode, we're going to cover some of the big talking points in health and care policy of the day. And rather intriguingly, I know Helen's keen, we're going to open the pod surgery, which is your chance to shape what we talk about. So you can email podcast@stevebryan.com, and we'll add social media channels to that shortly, and then you can decide exactly the subjects that we're going to go on.
And if the first subject is why on earth have you called it pod surgery and you can come up with a better title, I'm all ears. Steve's wedded to pod surgery. I'm not at all convinced. So what are we going to talk about, Steve?
Oh, well, I don't think we can do this without talking about strikes. The first thing, and then I guess, workforce is the linked issue, isn't it, to strikes? And I thought we might talk about prevention as well. The Select Committee's just been talking about that this morning with the Chief Medical Officer.
And it is basically what we call the podcast, so that seems very reasonable to me.
Yeah.
So, strike action.
Yeah, you've got junior doctors yesterday who've now joined the strike action, haven't you? You've got the nurses still on strike. Originally demanding a 19% pay rise, and that now I think they're now down to about 10%. Is the compromise that they've said, but the government don't seem keen, do they, to reopen the current pay deal? And just for people listening, so they understand the way it works, is that the independent NHS pay review body, I say independent because there are many theories as to how independent it is, that makes pay recommendations to the government, which they then accept or don't accept. And we are currently towards the end of the current pay deal, the 22-23. Government want to talk about 23-24. Unions want to reopen current one. Don't look like they're going to do it at the moment, though, do they?
No, they certainly don't, and it's really difficult. I think there's the strike action with the three main big health bodies at the moment: the paramedics and ambulance strike, the nursing unions, and now the junior doctors, the British Medical Association, the biggest medical union, where they've had the most remarkable turnout. They had 77% turnout, and of those who voted, 98% voted for industrial action. That is
so they feel strongly about it, don't they?
Our junior doctors feel really strongly about this, and that's sending a massive warning shot across the bows of everybody. When the most committed of our professionals are feeling like this, I think we do have to take it very seriously as a nation. But we need to think of the background that we're talking about here: a war,
COVID,
yeah. 3 years ago, COVID pandemic was taking off. And a year ago, a senseless war in Ukraine was kicked off.
I was Jeremy Hunt's PPS at the Department of Health during the first junior doctors strike, if you want to call it that, which was really about imposing the contract, wasn't it?
Yeah.
And this is about pay, but there are wider issues, though, aren't there? It's about the wider workforce stuff we'll come on to. It's about the demand in the NHS and how burnt out they are, as you say, post-COVID. And I guess in a way that's what worries me, because there are figures out there about how many planned procedures and tests that are cancelled each time you have a nurses' strike, let alone if you add the junior doctors into that. And I guess my worry is that all that's doing is adding to the workload stress that they've already got and just making it worse longer term, while you can understand the immediate need. I hear it all the time from constituents, struggling to pay the bills because inflation spiked.
So look, you're absolutely right. We're on the background of, in all the wrong ways, record backlogs, huge lists of people desperate for investigations and procedures and appointments. And every strike makes those worse, there's no doubt about it. With the nurses' strikes, up until now we've been having 12-hour strikes, but now they're looking at several days, a 3-day walkout. The junior doctors are now talking about 5-day industrial action. These are going to have serious implications on the ability of the NHS to deliver routine care. In fact, I think it's fair to say really significant.
Yes, and I guess the bigger picture is, if you gave a poorly paid nurse, and let's face it, a newly qualified nurse is not very well paid.
Yep.
If you give a poorly paid nurse a 25% pay rise, it's still not very much, because not very much of not very much is not very much.
Indeed.
If you're talking about, a higher end grade 5 nurse, well, 25% of that is quite a lot. And what worries me for the longer term, and I think the government are really going to have to wrestle with, is if you've got this many people in the health service and it's doing this many things, and you want to, so people say to me all the time, oh, well, the nurses should get a fair wage. And I always say, well, define a fair wage? Because, one person's fair is another person's unfair. So, if you're looking at what 1.2 million people are on Gender for Change, which is where a lot of the nurses, the porters, the non-doctored staff in the NHS sit, you're talking about £700 million for every 1% of the pay rise. So a fair wage would be significantly more than most nurses currently get. And how do we do that when at the moment I think health spending is rising faster than GDP? And it's very hard to see how government squares that circle, isn't it?
Yeah, but I mean, health's rising faster than GDP at the moment, but that is on a background of not keeping up with GDP for quite
100%.
a long time. So, the reason we're in this pickle at the moment is that we've got a legacy challenge to overcome. I mean, my worry at the moment is that all the conversation is about pay and pay rise, when in fact we know that what helps people remain in the workforce is much wider than simple pay. It's about being valued, about being looked after. It's about it being easy to come to work. And there are so many other things that would help. But the union narrative is all about the money. I mean, particularly the junior doctors yesterday. The talk is of 26% pay restoration up until April 22, not April 23, up to 22. So plus the 10% inflation of the current year, we are talking really massive sums here, and that I think is challenging. And what worries me is that I think for an elegant way out, a way out that everybody feels that they've got some sense of win, is going to have to go much wider than that. And we mentioned earlier the junior doctors' strike of 2015-16. The solution there was a new contract which was broad and included a range of initiatives to help well-being and morale. And I'm not hearing anyone talking about that right now.
No, I agree. And I remember somebody doing a piece of work for Jeremy Hunt, who was then the Secretary of State, of course, about the other issues. So, it's they used to call it the doctor's mess. It's about parking, it's about meals on site, and all the softer stuff actually on top of pay, which is one of the things that I hear all the time is what makes it more challenging to work in that. I mean, I guess the challenge that they have in making that argument is that, lots of people don't get to part free at work. Lots of people don't get, subsidised meals at work. And in an organisation as big as the NHS, it's a huge conundrum. And I don't know where the strike situation ends. Do you know what my theory is, Helen? Is that the landing strip that the government have got here is that the independent pay review body will do its work. We had them in before the select committee recently, actually. They will then produce their pay award for 23-24. And normally that comes out in sort of summertime. It's backdated to April the 1st. I think that could be backdated further. I think you could add in some kind of one-off payment. They don't need to take as long until the summer to come up with their report. All of those things could put it on a little bit of a fast forward, and that's how you could, that's the landing strip where you could try and end this, in my opinion.
I think then that could be accompanied by a range of things that we know could help well-being and morale. And I get your point about, not everybody has somewhere to park their car, but not everybody is walking around at 4 a.m. between buildings in dimly lit car parks and feeling quite scared for their own personal safety. Not everybody faces aggressive patients or intoxicated patients on a daily basis. There is a lot of stuff we do in the health service which is quite different from other parts of society. And I think recognising that, it used to be that people felt valued because of their vocation and people were respected for what they do. Society's changed a lot, and a lot of those, wow, you're a nurse, doctor, whatever, is gone. And with it, people's expectations of other things compensating are have become more important. I do think as a society we need a serious conversation about the NHS we want for the future, the NHS we can afford compared to the NHS we've actually got. There's a lot of good evidence out there that the public actually really like the concept of the NHS as it is. They just don't like the service they're getting from it right now.
Yeah, well, isn't that a good point? Because whenever I go on the media and do interviews, really, all they really want to ask me as the chair of the health committee is, are the government going to settle the pay rate? Are they going to pay them more? Yeah. And then they say, can I hurry you because we've only got a minute, Mr. Bryan? So that's what my wife said. That's what my wife says. But I mean, I guess the wider point, if we had more time to discuss it, is and I've tried to introduce this sometimes in interviews, is exactly what you say. What is the NHS that we want, and are we really prepared to pay for it? Because if you think about, Boris Johnson's government introduced a 1% increase in national insurance to pay for COVID catch-up and then social care. Lots of people didn't like that. Lots of people on my benches in the House of Commons didn't like that, so much so that Liz Truss government then got rid of it, and the Rishi Sunak government hasn't reinstated it. So, what are people prepared to pay for? Because to pay NHS staff the kind of salaries that we all think they deserve, where's it going to come from? And that's the difficulty if you're Jeremy Hunt.
And I mean, I think that there is a challenge of hypothecated taxes versus general taxation and how you split it up. And so there's a separate argument there, which I don't think is for us to get too distracted by. But the general principles about having an honest debate with the public, I do think that we underestimate the wisdom of the general public to make difficult decisions. There is really good research that if you ask a bunch of the general public a difficult question, they come up with remarkably sensible and pragmatic answers that surprise us. Because sometimes I think we patronise the public all too often, and I think we need to empower people better and include them in the decision making more wherever we can. I think there's a lot of lip service paid to patient engagement. I think it's sometimes a tick box exercise, but perhaps that's for another podcast.
Yeah. Should we take a break? We'll come back and talk about workforce.
I'd like to talk about workforce in the NHS.
That was an easy one.
I just thought we just solve that in the next couple of minutes, please. That'd be great. Okay, any news on when this fabled workforce plan is coming out? It's been in the pipeline for quite a while. We are now coming towards the end of February, and word was it had to be out before the budget.
So as you know, I used to be a health minister, and I produced the cancer plan when I was health minister, and I've said this in the House of Commons before. I hold my hands up that it was going nowhere because it didn't have a workforce plan attached to it. And the cancer charities quite rightly said, yeah, but what about the workforce plan? And, the long-term plan didn't have a workforce plan attached to it. So the select committee, when Jeremy Hunt was in my job, said about the workforce plan that it needs an independent assessment to it. Indeed. So my guess is that what will happen is the workforce plan will come out around the time of the budget. It will then be sort of consulted on with the Royal Colleges. It will then have that independent assessment. And we don't know who's going to do it. We had the Secretary of State in the other day and we asked him who's going to do that independent assessment bit of it. And I don't think they know at the moment. But I think it could be a collection of people. And then I think it will be finally sealed and published as a finished document around the autumn statement.
So look, for anyone who's listening who doesn't know much about the workforce plan and the intent behind it, I mean, we've never had a really comprehensive plan looking ahead of what the NHS is going to need the next 5, 10, 15 years.
And at least.
And it's a complex set of calculations. We've got, I think everyone is very well aware now of our ageing population. And when you get an ageing population, you have this increased complexity in that people live longer with multiple long-term conditions. So you've got this multi-morbidity and complexity issues. We know that there are loads of health inequality challenges which recent global events have exacerbated. And then you've got the dynamics of the health service itself. How is technology evolving over time? How is the way we deliver services and the healthcare professionals we use changing over time? How is the estate of the NHS able to better support more efficient working? But then for me, the underpinning question is, and what staff do we need to deliver it? And so I'm delighted that there's going to be an independent oversight of the plan. I think that's really important. It gives everybody confidence and credibility in it. But what I don't want is for perfection to be the enemy of the good, and to the whole thing to be delayed while we're waiting for some super duper review to delay us cracking on and doing what needs to be done.
I wonder, talking to people around health and care, GMC, they say it takes 7 years to train a doctor, and then it's 7 years to then become a consultant. So you could say, well, if you started now, you're talking 14, 15 years. Can we shave something off that, I wonder? Does it have to be the 7 years? Because that's a bit of a counsel of despair to think that we're 15 years from getting new doctors that start today.
But you're 15 years away from getting fully fledged consultants, autonomous consultants. But, medical school takes about 5 years. So, we have tens of thousands of amazing students doing their A-levels right now who want to be doctors. At the moment, we turn away 4 out of every 5 who want to be a doctor. We probably turn away 3 out of 4, 2 out of 3 of all those who could be great doctors. So we've got massive potential. In 5 years, there'll be junior doctors. They'll be out there on the wards treating the sick, delivering a huge amount of care. Within a couple of years after that, they can be locally employed, or not so long after that, speciality doctors delivering a high standard of care. It's that true independent consultant level that takes that bit longer. And we often underestimate the power of that middle level of what, we call them junior doctors. These are people who've been training for years and can deliver fantastic care. And most of the care you and I get if we're in a hospital is actually coming from the juniors. It's overseen by a consultant. So yeah, the Council of Despair is one thing, but we've got a whole heap of people in the system that are burning out and leaving prematurely right now. We can do things to help keep them in the system and support them and shore them up. We've got people who've left we could attract back. Quickest and cheapest thing to do is retain who you've got and return.
Yeah, because you've already trained them.
Exactly, you've invested in them already.
Can I say something nice about the Labour Party?
Yes, of course you can.
So
we're not party political.
I think we're not, and I chair a cross-party committee. I think that Keir Starmer and West Streeting are dead right about medical school places. Their policy to, I think, double the number of places. That has to be right. Because you're training domestically. I mean, I represent Winchester. Lots of doctors live in my constituency, and we know that children of doctors are often inspired to be doctors, and quite right. Good for them. I do hear from people who say, my son, my daughter, straight A student, can't get into medical school. We've got to increase the number of places.
Absolutely. I mean, this is what all the Royal Colleges have been calling out for this. The Med Schools Council's been calling out for it. All the people who really got their ear to the ground on this think this is absolutely the right direction of travel. So delighted to hear that. There've been other commitments to increase medical school places, and I think the trend is right. But I'm going to pick you up on one thing. Your wonderful constituency and your doctors whose children want to be doctors is fantastic. But I'm a professor also in Birmingham Medical School, and we've got some amazing initiatives with inner city Birmingham and kids who don't come from privileged families, where there's amazing talent, and increasing the widening participation, access to medicine for those who don't come from the obvious backgrounds. And the difference is some of your constituents' parents are paying their kids to go and train as doctors abroad. So they're still training to be doctors somewhere, which, it's not ideal, and other countries are then benefiting from the training. What I worry about with the wasted talent we've got, where parents and families can't pay for that isn't even an option open to them, or they don't think about looking for scholarships overseas. So I hate wasted talent. I know that medicine on a good day is the best career in the world, and I really want to encourage people to think about it.
Yeah. Can we talk about prevention?
Yeah, of course we can. We really should.
Yes, prevention. So, Select Committee this morning had Chris Whitty in.
Excellent.
The famous Professor Sir Chris Whitty.
One of my heroes.
I know, of Downing Street lectern fame, of course. As we kicked off our big prevention inquiry. And everyone always says, well, of course we've got to get serious about prevention. My theory is, without prevention, serious step change in prevention, NHS is in big trouble because demand is rising at such extent. I mean, we're spending in England, we're spending about 10 billion quid a year treating type 2 diabetes alone. And as type 2, of course, in large part preventable, and you can turn it round.
Yeah.
When you think about the obesity and some of the conditions that drives. So we're gonna have a real big old look at prevention. We kicked off the inquiry with Chris Whitty, and we were talking about all sorts of things, from air quality to obesity to smoking to sexual health. Everyone agrees prevention is the right thing to do. There is some lower hanging fruit, I think, in this. So I mentioned obesity, I mentioned smoking. I mean, over 3/4 of lung cancers are smoking generated and therefore preventable. We had the Calm report, brilliant report about smoking. Still yet to see a government response to that, and they need to get their skates on with regards to that. Everyone agrees prevention is the right thing to do. What does the doctor think?
It's such a no-brainer. But prevention becomes very much the poor relation of acute and urgent care. Prevention gets relegated because it can always be done tomorrow. It hasn't got the sense of urgency that other things. And that's one of the challenges of a health system which is funded on an annual rolling basis. essentially, if you've got a limited amount of money and you've only got a year in which to deliver, your KPIs are going to be the things that change in a year. And the problem with prevention is generally the measurable outputs are 5 or 10 years down the line. So I do think there is a challenge in politics to think about how you can take a step back and perhaps be a bit more Japanese about looking things at 25 years down the line, not just 12 months away.
What was that song? Turning Japanese.
No, don't start singing.
No, I mean, you're right. We do think in terms of electoral cycles, and of course they've been getting ever shorter with 2-year parliaments. And I guess, if you're Chris Whitty, who responsible for the nation's public health in England, and I guess over the years of the pandemic, was he thinking about obesity and how we can turn that super tank around, or smoking and some of the longer term public health? No, because he was dealing with the immediate challenge that was right there in front of him of a COVID pandemic. And that's the issue, is that how do we embed that into the health system? Now, integrated care boards are meant to be doing that locally. One of the things they're meant to do, one of the things they're set up to do, is to drive health improvement and to focus on prevention in their local areas. So in my area in Hampshire, there are totally different smoking rates there are in the northwest in Blackpool,
yes,
for instance. So there's that difference in approach that's got to be right.
So first thing, Chris Whitty was thinking about this stuff despite putting so much energy into the pandemic. And that was one of the things that really impressed me working closely with him, is that he would keep looping back to the unintended consequences of all the acute energy and all the focus being on infection control and the pandemic response was of the stuff that was sliding. And he was worried about it. And he was talking to people, to Tedros at the World Health Organization and to others around the globe about exactly this. And we predicted the challenge we're having. We have seen cardiovascular deaths go up for the first time in decades. The trend had been very much downwards, and suddenly there's an uptick in people dropping dead of heart attacks, which should have been preventable. So, cardiovascular disease, obesity, you've mentioned, smoking. For me, I think we can reawaken what we were doing pre-pandemic. So that's got to be stage one. Let's get back to where we were. But we need to go much wider. And for me, there is a societal thing here as well as a medical thing. Putting it all on GPs and their teams to do stuff is fine. But people don't want to be hectored. People want to be empowered to take more control in their lives. What they want is when they want to give up smoking, they want to know there's a smoking support service available for them. Most of those have been axed locally. When people are struggling with gambling or addiction of any description, they want support and help there. And these are not expensive services, but we've decommissioned them. They've been deprioritised. And if we put those things back in, we can help. We know that bariatric surgery for people who are morbidly obese makes a massive difference over several years, but we haven't invested in those services. And when people get to that point of being prepared to go under the knife, to reduce their weight, we need to be supporting them, not putting them in a 3-year waiting list.
Do you know, I think the government needs to grab the nettle on smoking. And we've talked before about a polluter pays levy of tobacco companies in the House. And I and Jeremy Hunt actually sponsored an amendment to put through a new levy on the tobacco companies, which I don't think anyone would complain about.
Nope.
I mean, they might, but they target young people to bring them into their product. And I think if we were to introduce a polluter pay levy on them and put that money into those smoking cessation services that you say as GP people want to stop, but they want some help to do it, then I think that would be the right thing to do.
And I mean, it's crazy. We've known for 50, 60 years about the harms of smoking, but there are new things coming online all the time that are harmful and problematic that we should be addressing. One of the mantras I have, and we haven't got time to touch today on environmental and sustainability issues, but almost without exception, what's good for your health is good for the planet. And I do think that there is a way of engaging people better by framing healthy living in a sustainability and good for the planet angle as well. It certainly engages young people better. People, as I say, don't want to be preached at, they want to be engaged.
I think we're going to return to prevention many, many times.
We certainly will.
One of the things that we're going to be doing in the inquiry is not just looking at health and care stuff. So, air quality obviously sits across the Department of the Environment. You've got issues around housing the determinant of, the original NHS was the Health and Housing Department. That was what Nye Bevan set it up to be, because he understood that poor housing was a determinant of poor health. And so we're going to be looking at all of those issues, and we'll be talking about it as we go.
And one of my passions is around social prescribing, and that was the recognition that health and well-being is much wider than the physical health and the mental health. It's also about the social factors in your health, and indeed the spiritual factors that help us feel good about being human beings and being alive.
Amen. Welcome back. Helen, do you know what I can feel coming on?
Oh no.
Pod surgery.
Oh.
Now,
What was that?
I'll tell you what that was. When I was a little boy, I was often in the GP surgery, in the waiting room, in Hazelmere, Surrey, where I used to go to the doctors. And they had this thing up on the board where the doctors' names would be sort of slid in so that when they weren't there, it could be slid out. And I guess instead of it just them calling your name, what would happen is this light would go on and that noise would happen. And so I've been looking online for that noise in preparation.
A 1970s doorbell.
It's 1970s, how dare you?
But am I wrong?
I love that. A 1970s, yes, it was a 1970s. Thank you, Helen. A 1970s, 1980s. He had doorbell, which used to come on to tell me that Dr. Randall would see me now. Anyway, so pod surgery is open, and we've had so many suggestions of things to talk about. Mr. Wolf, who was asking what the time is. No, he wasn't really. But he was asking about access to GPs. Now, GPs, my goodness, have had a battering in the Daily Mail, so you must be doing something right. But they have had a battering over since post-pandemic. Fair or unfair?
A little bit fair and the vast majority unfair. So, I know firsthand the massive onslaught of care that people have needed since things after the initial phases of the pandemic. So we've got a population that is sicker, more frightened, more in debt, and more uncertain about their future than they've ever been. And that has a direct knock-on effect in terms of GP services. So GPs are providing 17% more appointments than they did pre-pandemic on a smaller workforce, and that's just England statistics. It's similar in the devolved nations of the UK. So there are more patients wanting appointments and fewer GPs to give them. And because of the way the pandemic made us work, almost every surgery moved over to you have to book your appointment on the day. So there's this hideous 8 a.m. scramble to get an appointment on the day with a much smaller amount of appointments pre-bookable in advance. And that's probably where the biggest thing is. So when you break down and do surveys as dissatisfaction, most of it is on getting an appointment. Once people get an appointment, they're just as satisfied, or almost as satisfied with the care they receive. They still trust their healthcare professionals, they're grateful for it, they feel that they're having personal care and that the system is working for them by and large. And when people are seriously ill, they feel the system works extremely well for them. It's that getting through the door. So in terms of what Mr. Wolf is asking, absolutely, I'm going to say we need a greater number of GPs and the wider team in the community, because this is not just about GPs, it's about every member of the primary care team. But we also need a state that works for people. We need telephone and IT systems that work to enable us to communicate better. And I think we need a communication campaign with the public about how the health system has changed over the last few years, what you can realistically expect, and what's just no longer going to be there, what's gone for good.
So it's interesting you mentioned the 8 or 8:30 a.m. scramble. So the government have brought out their elective plan last year when Sajid Javid was health secretary. Then just at the turn of this year, they brought out their emergency UEC emergency unplanned emergency care plan. Yeah, is that? Thank you. And the final one of the three is the primary care plan.
Yeah.
And I think that's going to come out next month.
I'd love to see it.
And I think that is going to address this 8 a.m. scramble. I don't know how, but I think that's going to be its biggest challenge. Is the other challenge with primary care, with general practice, is younger people, who I don't include myself in, as you've already identified me as being a child of the 70s, do we worry that they're giving up on the NHS and that they're happy to go for online app doctors, and they don't. The idea of going to see a GP in person is a bit weird. It's a bit of an anathema.
That's not my lived experience, Steve. I mean, yesterday I was in practice dawn till dusk. I genuinely did a 14-hour day. It was a bit of a bruising one. And I saw quite a lot of young people in person and some on the phone. And some of them, I offered video consultations and they were quite happy to speak on the phone. And others contacted us by email. So they are happy. In general, you're absolutely right. They're much happier to use other ways of consulting other than the face-to-face. A lot of my older patients still don't think it's a real appointment if they've not seen you face to face, when in fact they're having just as long, if not longer, on the telephone, and they've saved all the hassle of coming up to the surgery and getting parked. But for them, they've had a lifetime of face-to-face consultations, whereas for younger people, what they want is convenience and rapidity, as well as quality of the response they get. So certainly we see people using these online apps, but I would have said initial enthusiasm for those dwindled a lot once the NHS, because of the pandemic, started doing much more of it. So interestingly, some of those commercial companies, their model was blown out of the water when the pandemic came, because the IT suddenly was opened up for general practitioners.
For everyone.
For everyone.
Yeah. Do you know what I think is going to happen is the Secretary of State notoriously loves his data.
Yeah.
I think, and I was in a meeting with him recently where he was showing a prototype, a working prototype of a sort of dashboard, if you like, in each area of access to general practice in that area. And then, when people say, well, I can't get an appointment in my surgery, you can see how they compare with other surgeries in that immediate area. And of course, patient choice exists so that you can choose to go to another surgery if you're not happy with yours. And does that, that kind of sunlight being the best disinfectant, as David Cameron used to say, is that a good thing, or is that a threat to general practice? I mean, I don't know. You're the expert.
Well, I'm not an expert. I can tell you my lived experience. I mean, there's opportunities and threats in there. So sunlight is helpful because most healthcare professionals are inherently quite competitive. We want to be the best. We want our practice to be the best. We want to feel we're delivering the best for our patients. Actually, in my practice, if we suddenly were providing a better service in the practice next door and everyone started flooding to us, we'd close the doors. We can't take it on many more patients. We're at capacity. And so I think there are unintended consequences when you do that sort of thing, because you destabilise the practice that's already struggling, and you then push everything into a practice which just can't cope, and who in turn will then offer a less good service, because we're not like Tesco's, who can get staff in quite easily if demand goes up. It doesn't work like that in healthcare. So I think you're better off supporting all to improve rather than... So I'm definitely a carrots, not a sticks approach kind of person.
Yeah, okay. Who have you got?
Oh, well, I had a message from Kate Sanger asking about cervical cancer and cancer screening.
Oh, my goodness. Well... So there are, I mean, as you be the cancer minister, as you know, I mean, there are obviously, my father passed from pancreatic cancer shortly after the 2019 general election, notoriously difficult to spot and often spotted at late stage. And my mother died of breast cancer, and found early, very treatable in the vast majority of cases. Cervical cancer, in my experience, is one of those that, we really can beat. And Chris Whitty was saying this morning, that he can see a time when because of the vaccination program, the HPV vaccination program, which I, in my time, rolled out to boys as well as girls. He sees a time when we can, almost do away with the screening program because the vaccination rates are so good and so high, because cervical cancer is a very beatable cancer.
So two things from me. First of all, I share your pain on pancreatic cancer, having lost my dear friend, Professor Dame Claire Marks, chair of GMC, to it.
Yeah, I know
not so long ago, and being there when she was diagnosed. And you're right, that's very difficult. But cervical cancer, so much of it, because of its association with infection with high-risk types, HPV, human papillomavirus, I do think we need to go further and harder on vaccinations. So, what percentage of our young people are taking up the opportunity to be vaccinated? And if they're not being vaccinated, why not? We should be pursuing, and you can do that through incentives. We've got great exemplars of how we can do stuff better. And we've learned so much from the pandemic about how to reach out to people who are sceptical or concerned or anxious about vaccination.
Yeah.
One of my formative experiences as a medical student was nursing a girl with cervical cancer who died, and she was the same age as we were. We were 23 years old, she and I, and my firm were also a few other girls, and we were all the same age, and she died in front of us. And she'd had cervical screening that hadn't picked up her very aggressive disease type. So traditional cervical screening was great, but always missed some. Prevention is the new cure, is exactly what we're here to talk about. Let's get everyone vaccinated, male, female, and people later in life starting new sexual relationships. I personally think we should be offering HPV vaccination. You might, just because you're 35 or 40, you're starting a new relationship, you need to be vaccinated.
Yeah, well said. We've got to end. One final one as the surgery. Christina Millam, who's asked about social prescribing. What is social prescribing? You know a bit about that because you said at the introduction at the start. What's the Idiot's Guide to Social Prescribing?
So I have Matt Hancock to thank for my great interest in social prescribing, another of our former Secretary of States for Health, who was around at the time when the NHS contract in England was changed and social prescribing was brought in as part of the new 5-year NHS plan. Social prescribing is all the stuff that's good for us that is out with what the health and NHS and care system offer. So social prescribing aims to help people live their best life, and that's by offering a range of things to them. It may be advice and guidance and support, so that's help from charities. It could be encouraging people to get out in green and blue spaces. We know that being outdoors is really good for our emotional health well-being. It can be about arts and creative activities. We know that doing something creative helps us, enriches us, makes us feel better as individuals, and of course exercise. There is almost no condition and no state of being where doing some exercise doesn't improve it.
Mostly mental health,
but hugely physical health as well. It's a combination of all these things, and I think for me as a GP, a huge amount of my time is spent helping people whose problems are not physical or mental but are actually socially focused or sometimes spiritual. And once we understand and look holistically at our patients and recognise things, I'm a GP, I do the medical and the mental health stuff really well. The other stuff is not my area of expertise, but when I recognise it, when it comes into my consulting room, if I can help people find a way through, and traditionally what GPs, but also what MPs, priests, bartenders, hairdressers did is help signpost people to a charity, a club, a group. You know, as an MP in your surgeries what you've done for your constituents, they will get on and their lives will be better and richer. And I'm pretty passionate about it. We could spend a whole podcast talking about it, but that's a high-level flavour of social prescribing. Happens to think it's not a great name, but we're stuck with the name now. It was stuck a few years ago.
Yeah,
it is what it is.
Isn't it? Yeah, I love it. Well, look, I mean, it's fascinating. I think we're going to talk about that one more. There's so much to talk about. Look, I really enjoyed it. Our producer says that I've got a barrelly voice, so I hope it comes across well. We're new to this. This is a brand new podcast. It's called Prevention is the New Cure. There's going to be many more of them. If you want to influence what we talk about, podcast@stevebryan.com, and find us on social media, and we'll see you next time.
We've had fun. Thanks.